Good afternoon to everyone. On the beginning, I would like to say that Dr. Adam Kolesnik is not present because he couldn't connect for the place where he is. So I'm sorry for him. I have no conflict of interest. And when we talk about late vascular complication, from the beginning, I would like to say how is our protocol of monitoring after liver transplantation. Every patient after liver transplantation, in the first 7 post-operative days have ultrasound examination 2 times a day and 1 a day following week. And we do ultrasound exam at every follow-up visit. And when we do additionally when we have some clinical sign of complication, for example, elevated liver enzymes, and before and after surgical operation, no matter what the indication is. When we do Doppler ultrasound assessment of vascular vessels, we want to know what is the flow, velocity, and diameter of the vessel before, at, and after the anastomosis. Computer tomography we do when we have some suspicion of, for example, stenosis, to confirm and to evaluate this stenosis. And the second thing, very important, is anticoagulation protocols after liver transplantation. In our department, initially patient receive enoxaparin twice a daily, and after 2-3 weeks, we switch to acetylic acid. The first case is the 16-year-old patient, initially with biliary atresia, who underwent 3 liver transplantation. The second transplantation was due to biliary complication. It was very difficult hepatectomy. On the screen you see the abdomen of this patient, and also this patient underwent splenectomy. In this patient there was absent inferior vena cava, so the venous anastomosis was end-to-end. And we also perform aortic conduit because the recipient hepatic artery was very small, and we observed intimal dissection after opening this artery. We, as arterial conduit, we use iliac artery from the donor. After liver transplantation, this patient had acute kidney injury and needed continuous hemodiafiltration almost 2 weeks after liver transplantation. He also underwent surgical reoperation due to hemorrhage on first post-operative day, and the flow in hepatic artery portal vein were normal. On post-operative day 12, we observed increased intra-abdominal fluid losses, recurrent intra-abdominal bleeding, and we have suspicion of hepatic vein anastomotic stenosis. We did computer tomography, and we found that there was a stenosis after 2 previous retransplantation. There was stenosis and kinking of venous outflow, and the same day we take this patient to interventional radiology. You see this very narrow stenosis and kinking of vascular outflow. We place a stent, and this stent was dilated to diameter of 10 millimeters at the beginning because it was 2 weeks after liver transplantation, so we were a little afraid about anastomosis, not to damage this anastomosis. And the next day, patient underwent reoperation due to bleeding. And we wait 30 days from initial procedure, and we redilatate this stent to the 20 millimeters. This is a movie from this dilatation. And after this second procedure of dilatation, this is how looks venous outflow from transplanted liver. We didn't observe any other complication in this patient. The patient was discharged 2 weeks after this procedure. In case 2, I would like to show the 20-year-old patient who underwent liver transplantation due to unknown etiology. The patient underwent living donor liver transplantation. Our technique is piggyback technique. We do left hepatic vein was situated in triangular fashion to the confluence of left and middle hepatic vein. We use non-absorbable 6O monofilament sutures to do this anastomosis. And in post-operative course, we observe refractory ascites. We also, 2 weeks after liver transplantation, this patient needed reintervention due to bleeding. We observe liver rupture. This patient also developed pleural effusion, and in computer tomography we found stenosis of hepatic vein, and this patient was qualified for interventional radiology and dilatation of this stenosis. In first picture you see how it looked when we this was also very narrow stenosis, and we also did intravenous ultrasound. The diameter of the tip of this ultrasound is about 2 millimeters, so you see how narrow it was. And patient underwent balloon angioplasty. You see the little incision on the balloon. This is the place of the anastomosis. And this is the control after dilatation, and also you see the ultrasound examination, which is very helpful to assess the exact diameter of the vessel, and sometimes we can observe how it's look, if there are some scars around the vessels, and we can predict the course after this dilatation. The first case is a patient with portal vein and hepatic vein stenosis. This is 11-year-old patient with biliary atresia. Patient underwent liver transplantation from deceased donor and also underwent splenectomy. This patient had venous anastomosis with standard technique, that means with resection of retrohepatic vena cava and two end-to-end anastomosis. Portal vein anastomosis, diameter of this anastomosis was 10 millimeters. We use monotime 6O. We also do growth factor during this performing this anastomosis, and there was single arterial anastomosis with diameter 4 millimeters, and for such small caliber we use Prolen 8O. In post-operative course, this patient underwent surgical revision due to bleeding in day 3, and also needed reanastomosis of bile duct to Roux loop due to biliary leak on day 7 after liver transplantation. After 4 months, we detected stenosis in ultrasound examination. We confirmed it in computer tomography, and you see view of this stenosis before and after dilatation. And after this procedure, portal vein stenosis wasn't a problem in this patient. But this patient also had hepatic artery stenosis, which was seen in ultrasound examination and in computer tomography. And after 2-3 days, we perform hepatic artery dilatation. This is very narrow and long arterial stenosis. You see the picture of hepatic artery tree after angioplasty. There was no flow to the liver, so our radiologist decided to put a stent in the place of stenosis, and this is a view of artery after dilatation and stent placement in the place of arterial stenosis. But when we assess this patient 40 months after stent placement, we saw another stenosis in the stent. So our qualification was to dilatation of this stenosis, and unfortunately, during this arterial during dilatation of stent stenosis, there was dissection of artery, and you see the contrast outside the vessels, and we put another stent, but after 3 years there is no hepatic artery flow to the liver, and the patient developed stenosis of biliary anastomosis. Now this patient is biliary drainage and has repeated balloon dilatation of biliary anastomosis. And the last case I would like to show you is the stenosis of portal vein. It's 11-month-old patient with hepatoblastoma who underwent living donor liver transplantation. We use as a graft left lateral segments. The anastomosis diameter was 8 millimeters. We use monotype 6O. After liver transplantation, we didn't observe any surgical complication. But after 3 months, patient developed sign of stenosis in ultrasound, which was confirmed in computer tomography. But I would like you to show this patient because the dilatation of portal vein stenosis was done under ultrasound guidance. You see the place of stenosis here, and also you see it when we use intravenous ultrasound probe. On the next slide, you see the placement of balloon and positioning in the stenosis. As you see, the balloon and the place of stenosis is seen very, very well. And this is the dilatation of portal vein stenosis under ultrasound guidance. And this is control after ultrasound dilatation. So this was the one of the first procedure which we did only under ultrasound guidance, and in simpler case when we have first stenosis, now we do without X-ray control. And on the end, I would like to say that the advantages of interventional radiology in managing complication after liver transplantation is that this is very effective treatment of vascular stenosis that in many patients prevent from vascular thrombosis. In our department, we didn't observe late portal vein thrombosis since 2014. This approach is minimally invasive. We observe lower complication rates. As you saw, this is precise image guiding intervention, and this procedure could be repeated. There is a group of patients who need 2 or 3 dilatation of portal vein stenosis. Thank you.